So let's start off by getting you guys in the right mood. How many of you really believe that you could be as good an injector as myself or Kent, if you consider us to be decent injectors? Even better than us. Keep your hands up. Keep your hands up. And have even a more robust practice. Do you really believe it? I don't hear it. Do you really believe it? Yes. You damn well better believe it, because you definitely can. There's just no question about it. If you believe it, it will happen. And I'm truly convinced of that. And I was talking just before to a couple of colleagues outside, and you have to understand something. You know, as a plastic surgeon, if you look at me as a plastic surgeon, people say, well, you got all the advantages. So what are the advantages? Well, your knowledge of aesthetics is much higher than average, much more higher than anybody, typically in the room. Okay? And your understanding of anatomy. You're strong in anatomy and you're knowledgeable in aesthetics. So I'm going to say something right now. You tell me who said it. It's not the strong who survive, nor the most intelligent. It's the ones who adapt. Who said it? Charles Darwin. Absolutely right. I see so many practices dwindle down because people are not adapting. Understanding that injections are here to stay and they're a very integral part of any aesthetic practice. I sit there and the heretic, the frustrated dermatologist, as they call me, all my plastic surgical colleagues, when I get up at ASAPs and I start saying, guys, you got to indoctrinate this stuff into your practices. Why? They laughed. I remember in 1982, when I started doing 82, 83, with this young man over here as my senior chief resident in plastics, we started doing liposuction under the auspices of a doctor from Alabama who was running the program up in McGill. The reason why I lost so much of my hair, the reason his hair turned white. This guy was a toughie, but he said, you know what we're doing tomorrow? We're doing something called liposuction. I said, liposuction, what's that? And he brought in this machine. He said, what is that? I said, that's a Berkeley suction. That's in order to do therapeutic abortions. He said, well, we're going to use that machine to remove fat. I said, really? He says, yep. He says, we got 3 cases booked. He said, I don't have a clue what it's all about, so you're going to do them. Remember, that was the way he was. And you'll do it, and you'll do it well, he used to say. And I remember going on my fellowship, and I went down to Miami. I was over here at Jackson Royal Fellowship with one of the icons in plastic surgery, this guy Millard. And I said to him, wow, I just started doing this liposuction thing. That was back in 86. Nobody had heard about it. And he said, what are you doing that for? That's not surgery. That'll never have any legs. It'll never get anywhere. Number 1 surgical procedure that we do in plastic surgery. And when I started doing toxin and filler in my practice, all my plastic surgical colleagues looked at me and said, that's ridiculous. You're a surgeon. You shouldn't be sticking needles in people's faces. Leave it to the derms, right? Number 1 procedure, period, that's being done aesthetically right now are toxin and fillers. So you got to adapt. And you guys can do it, and you can do it well. So who do we have up here now that we're going to do a little bit of measuring on?
Yeah. And I think just in following up with this, I think everyone in this room has heard of Benjamin Franklin. Said if you're finished changing, you're finished. So change isn't always better. In fact, as I said last night, different isn't always better, but better is always different. And mathematics, I think if you follow math a little bit, and we both have a little admiration for math, is we hope we'll convince you that outstanding aesthetic results from syringe therapy, whether using fillers, neuromodulator, or Kybella kind of things, syringe therapy, is a result of good mathematics. So as you start measuring, it's easy to measure patients with calipers, and I use an obtuse angle protractor as well for noses. And it's easy to measure and document, but it's difficult to translate those measurements to what you do. So this session, this weekend, we hope we'll go beyond that board, because I've attended a few clinics here recently that could find their calipers in a drawer somewhere, but they don't use them because they don't know They know a little bit how to use them, but they don't know how to implement them. So how you implement them, and we'll try to show that, Arthur, how you actually transfer those measurements into reality.
Right.
Because not all our patients are phi. And that's, in fact, we could have Hannah. Hannah is a PA with Dr. Comstock. She's a dermatologist in Tucson, and so she's volunteered 10 minutes ago to be one of our, and she's just looking at her, yeah.
Let's put
Arthur,
this
why don't you do the measurements here? Since
why don't we just put her here while we're getting her set
Hannah,
up?
you can actually look at Hannah, and with your, I draw and paint. And so, I mean, you could look at Hannah and almost within milliseconds know that she's fairly phi. So we should measure. Why don't you measure?
Yeah, I'll just give you a little bit of the background on how this whole thing started. Going back around 2005, 2006, what happened was I was doing a lot of toxin and fillers in my practice, and I just wasn't happy with the results. You got to do, it's a terrible word, but you got to do a post-mortem. I do it on all my surgical cases. I do it on all my aesthetic cases. It means that you have to take a look and look at the results afterwards and say, what did I do and what can I do better next time? Okay? If you don't really, you can't manage what you don't measure. You have to, that's why you got to do photography. You're looking at the king of photography over here. And take a look and say, well, this is what I started with. This is where I got there. Yeah, sure, I improved them. I mean, come on. You can always improve somebody, but the question is, did you improve them? Did you hit that sweet spot on the golf club like Bob was talking about? And what happened was at that very time is that I was actually, before I went into medicine, I was in music. Kind of a weird thing. And I was supposed to be talented. I was supposed to be artistic. And yet I couldn't understand why some patients I was getting beautiful results and some patients I was getting average results, and I was trying to do the same thing. I was doing the same techniques, I had the same methodology, I had the same thought process, and I just wasn't nailing it all the time. And I didn't know who to ask. I really didn't know who to ask. I mean, I was struggling and trying to figure this out, so I said, why don't I ask the most intelligent person that was, about aesthetics and science? The only one problem was, he's been dead for 500 years. So I went back and learned everything about Da Vinci I possibly could. And I realized that this guy was measuring. So I said, maybe that's the thing. Maybe there's something mathematical that I'm missing on the face. So I said, I got to start measuring, but I didn't even know where to start. So I started reading as many articles as I could on beauty. And I happened to pass, and then I got myself a set of calipers off the internet, which, by the way, were only being sold for automotive things. So they were like this really weird looking type of pentagon-shaped thing.
Yeah.
And very big, actually. And I started measuring things and trying to figure things out. I had no clue where to start, and I kept reading about it. And I read through Steve Marcot's stuff, who's probably one of the pioneers in this stuff, about the phi concept on the face. Still didn't make sense to me. I couldn't put it together. And then I came across an article by Steve Hoffman, who's a California-based plastic surgeon who's now retired. You probably know him as the guy who operated on Michael Jackson, but like 50 times. But Hoffman came up with this article that said, it's interesting, when you look at the aging face, once you hit puberty, once your face has found its happy spot with respect to the skull, what happens is that the distance between your eyes, the intercanthal distance, doesn't change. It stays the same. And when you think about it, what that means is that if that point is fixed, everything else on the face, like I told you yesterday, is constantly moving and evolving and changing and modifying. So it's a rotation point at which around everything else starts to move. And I said, well, wouldn't that be interesting if I have a patient that comes in, how old are you, by the way?
I'm 25.
25. Oh, my God. Okay.
She was just born.
She is wet behind the ears. I do see that. Okay. Somebody comes in who's 25, beautiful, and should be beautiful, and everything should be, look at the smile, should have a smile on her face continuously. If she comes back at 35, things will have changed except for one thing, the distance between her eyes. So if you have a starting point that at 45 and 55 is going to be the same, in the absence of disease, that thing is going to stay the same, you have a starting point from which you can measure to recreate what she was like when she was 25 or 35.
And that's why when you look at photos that we do, if a patient is 50, and you have them bring their photo in at 20 kind of thing, and you put the photos together, that's why you can tell they're exactly the same size, because the intercanthal distance that we measure is the same. So that's another way of telling exactly the same size of the photos, for instance, even though they're two-dimensional.
Correct. And so what happened was I said, well, wouldn't that be great if you started measuring from there? So I was sitting in my underwear in the kitchen, this is the story, with this caliper with about 400 photographs, anything I could pull off the internet or from magazines that had AP views of all the celebrities and beautiful women. And I started measuring between the eyes, and then I said, okay, now where am I going to find, that was one, where am I going to find the 1.618 on the face? And I started to pull, and I said, holy cow, look at that. If you measure the inside of Angelina's eyes from canthus to canthus, her cheek width is 1.618. So I had that kind of eureka moment, little shriek. My wife said, what's wrong? I said, I think I'm onto something here. I said, take a look at this. And I showed her the measurement. It was actually on Angelina's face. And then she looked at me, she said, she says this every day, you're an idiot. It's just to keep you, on even keel. I said, why? She said, first of all, don't ever sit in the kitchen in your underwear again. I said, okay, I'll give you that one. She said, but it's only one person. How does it work for everybody? I said, you're right. So I started measuring all faces. And I was measuring Halle Berry and Lucy Liu, and I was measuring Charlize Theron, and anybody that I could possibly think of, Beyonce. I mean, as we were going down, I was measuring and saying, damn it, everybody's falling into that 1.618. So that started it. My other smarter half of the brain said, we always email each other with these different thoughts.
Crazy ideas.
Crazy ideas. And I said, there's this crazy idea, and what do you think about this? And then well, this guy, it's like you plant a little seed, and then the next thing you know, you look in your backyard, and there's a huge tree. He just flew with it. And we started measuring everything on the face. And what happened was, it changed my entire practice. Now, I'm not saying that this is something that's going to be the most biggest game changer, but I'll tell you what happened. I had this tool. I couldn't wait to get into work on Monday morning. I got into work on Monday morning. I had it in the drawer. First patient walks in, and she starts to say, fill my lines. I didn't even listen. I said, wait. I said, listen, I'm studying beauty, and I just realized that there's mathematical beauty to the face. I was reading about Da Vinci. I would love to measure your face like Da Vinci measured his models. Do you mind? And of course, she said, yeah, sure. I'd like to see how I work out in beauty. And I took out this thing, and I approached her. It looked like Edward Scissorhands with like 20 things. Patient recoiled, which is why we came up with a better-looking caliper. And I realized that it changed the whole concept of the consultation. I didn't expect it. There's so many little things that happen that you don't expect, that you're so happy about it. Why? She's walking down the street over here. My practice is right next door. We go out for lunch. Not her and I, but I'm going out for lunch, and I am the messiest eater you've ever seen. In fact, the girls keep a bib for me at the office because I'm always getting my white smock dirty. I'm coming back from lunch, and maybe I have a little mustard stain on my collar, a couple of crumbs hanging from my lip or something, and I pass her on the street. Okay? Right? Just pass her. That's it. She doesn't know who I am. I don't know who she is. 5 minutes later, she's sitting at my examining table in my office, and I walk in my white lab coat. And she looks at me and recognizes me. Is she nervous? She's terrified. She's thinking, wow, this is the guy that couldn't get a fork in his mouth, and he's going to stick a needle in my face. Right? It's not a very comfortable experience. She's thinking toxin, needles, pain. So her position in her chair is she's pressing against the chair, putting distance between me. I say, hi, I'm Martha Swift. Nice to meet you and everything. Great. Can I get a little information from you? Grandpa's. Gender, race, age, medical history, any surgeries, whatever the story is. Previous injections. We'll get all this stuff out in a second. What's your aesthetic wishes? I take a look at the face shape of her face. I've done that in literally 2 minutes. And then I say, what are your aesthetic wishes? And what does she say? Fill my lines, right? I say, yeah. A lot of patients will focus on the 2D as we were talking about yesterday.
Do you measure every consult?
I don't measure everyone because now it's kind of in my head. I measure the ones, and I'll show you what happened. But this is where it changed the whole process. So she'll say, fill my folds. And I'll say, yes, I will. But you know what? I'm a student of beauty. Here it comes, guys. Here's the pitch. But it's not a pitch. I'm a student of beauty. I love to study beauty. And would think there's some things about your face that are absolutely stunning. A lot of things about her face that are stunning. right? Every single patient has a beautiful feature. Everyone. God forgets nobody. Okay? Everyone has a beautiful feature. You just got to bring it out. Do you mind?
Sometimes you have to really look for it.
He works in mysterious ways, yes, or she does.
Sometimes
I believe
it's just
she's
the
female.
shoes.
That's right. That's it. So I'll say to her, I think there's some features on your face that are absolutely stunning. Do you mind if I measure you like Da Vinci measured his beautiful models? I'd love to be able just to record in my chart your beautiful features. Do you mind if I do that? It's the only time in my life I've never been refused by a woman. Okay? Literally, I've never had a patient say, no, don't measure me. And not only that, but
they love it.
They love it. Not only that, it's the only consultation that I do in my practice, the only consultation that I do that I allow somebody else to sit in the consultation room, a friend, a family member. Otherwise, it's one-on-one. But not this time, because as I take out the calipers and I start to lean over to measure, what do you think the friend is doing? Straining around me to see how her friend measures up. And what's the next question that's going to come out of the friend's mouth? Can you measure me? It's unbelievable. Now I have 2 consults, which I can't handle, but on one consultation, I picked up 2 patients. This is the first thing that I started to notice. The next thing that I started to notice, I start to measure, so we'll take out the calipers, and we're going to do that in a second on her, and I start to measure, and as I measure, I say, oh, look at that, your forehead's beautiful, your eyebrows are beautiful, oh, your cheeks are a little bit off, according to Da Vinci's golden ratio, because as we age, we lose a little volume in our cheeks, and things start to settle down, and then it causes the folding over here. Now, I haven't said anything except talking about beauty, anatomy, aging, right? And then we go on for the rest of the face, and I say, okay, and this is how I do it. I say, okay, let me go get the syringe, and I'll fill your folds. And the patient, 76% of the time, 3 out of 4 will look at me and say, well, wait a second. Didn't you say everything else is perfectly proportioned, but my cheeks are a little bit off? Can't you do anything for my cheeks? Bingo. Hook, line, and sinker. I haven't told her I want to inject your cheeks because she's thinking this. I've drawn her attention to the fact that this is the disease and this is the symptom. As we deflate over here, we start to crease out more. Some of us have it genetically, but it gets worse with age because of that. And now she's asking me for it. There's a difference between an ask and a tell. When they ask for it, they're prepared for it. When you tell them for it, they're backing off. And I'll say, yeah, sure, we can. If it's something I think I can handle right there in my consultation, I have enough time for it, there's not 20 patients screaming that I'm running late, I'll do it. If not, I'll say, yeah, we can do that type of thing. Let's book a proper appointment. We'll go through it properly. And the friend says, I want a consultation too. 2 for 1. So what is my retention rate? When I looked at my retention rate in my practice, people say, wow, you have a 70% retention rate. That's pretty good. My retention rate is 112%. You say, how's that possible? Because I'm picking up extra consults on the second. Who has a retention rate of 112%? That's crazy. Every patient that comes in all of a sudden starts to generate almost 2 patients. So that was the first thing. The second thing I noticed is that the shoulders were relaxed. Of course they're relaxed. Have I mentioned needles, pain, toxin? We're having a conversation about beauty and math. There's no anxiety in that. And that's what I didn't expect. The experience became over the top for the patient. It was an experiential thing that they understood. Not only that, but if you're a female injector, you have it all over us. Because it's like she's out for lunch with her friend discussing beauty. Where's the stress in that? And that's what started to snowball in my practice. And using this, it became a confidence tool. Because patients come in with these ideas that they're going to look all blown out and stuff like that. Or they'll come in with a brochure and they'll say, look at this brochure. Look at the beautiful result. It's a brochure from one of the companies. Did you do that? I might have. Maybe Kent might have. But I'll say, no, that's not my patient. Well, how do I know that you can do what this doctor did? Because I'm going to measure you the same way that he did. Oh, there's a way to measure? Yeah, sure. It's a confidence tool. I know when to stop. It's a confidence tool for the physician. You feel more confident, and they feel more confident too.
What's really interesting as well, as patients that a little more mature than she is, that her Phi, often my most gorgeous patients have a low self-esteem for some reason. Their self-image, their self-awareness isn't great. So some of the some of the tears I get in my clinic are patients that are perfectly fine. You tell them, you're absolutely amazing. You're perfectly mathematically perfect. And yet, there's not such thing as perfection. You can always find some issue with patients. So it is, even in patients that have that sort of won the DNA lottery, they still, it's a very, very enhancing experience for them.
Look how much better she looks in the monitor when I'm next to her. Everything in life is comparison. People say, why don't you do stuff? I say, because I'm taking one for the team. If I look old like this, my wife looks a lot younger. All right?
Don't emphasize the miles.
That's it. We don't emphasize the miles, just where we've been. So I'll say to her, can I measure you? And she'll say, absolutely, go ahead. When we do the sessions, I usually have physicians who come up and say, measure me. I want to see how I'm doing, how I'm rating. And I'll ask her, the first question is, do you wear your hair up or down? She's obviously showing us what she does. But I ask patients, do you wear your hair up and down? Because women are amazing. They understand proportion in their face. If their forehead is too high, down comes the hair covering it. If their forehead's too low, down comes the hair
covering it. Not always, but intuitively.
Intuitively, yes.
Intuitively, usually know.
So I say, okay, close your eyes. I want to measure that beautiful distance between your eyes. And we've never measured her before. And this is the first measurement
Show me exactly where you measure. Open your eyes a little bit, dear.
Okay, so I'm measuring from intercanthus to intercanthus.
Distance.
Okay, the intercanthal distance.
And
I'm using the small part of the caliper. And I just tell the patient, you know what? As often as I see, let me show you here, as often as I see this distance and this distance on your face tells me how beautiful you are. Simple. Don't start having to get into the whole idea, golden ratio, and this and that. But this was the concept behind what Da Vinci believed in. As often as we see the 1 to 1.618 ratio across features, across anything in the face, tells us an idea of how beautiful you are. And I'd say, well, take a look. Now I understand why you're wearing your hair up, because you're exactly 1.618 height of the forehead. And you'll notice that in most really beautiful women, their forehead follows their brow.
Yeah.
Very, very commonly. So she has a 1.618 over there. And then we'll take a look and see what's the distance of her eyebrow. Oh, look at that. She's very close. 1.618. And I have the patient looking in the mirror. And I say, let's see where the peak of your eyebrow is.
Before you go, show them that the head of the brow is equal to the tail.
Yep. Right here. We see that. Because an ideal brow in a female, okay, I'm going to show you all the little nuances because you can get into very fine details. But what am I doing now? We're examining her face together, and she is on the same page as I am because we're talking very simply about mathematics and something that she can very basically see. If she had and that's where her peak of her brow is right over here. You see, it's 1. If I wanted to create a peak and a flat brow, it tells me that this is where I should create it. Not here. And not there. Okay? So that's it. If we take a look, and we can go down the face and we'll go through each area just individually, but I'm just doing it quickly on her because she is so bloody fine. Look at the width of her nose. Let's turn you a little bit straight to the camera. Look at the width of her mouth. Look at the width of her chin. And then the one that
before he goes on, show him the intercanthal distance and the width of the nose should be the maximum volume of the lower lip. So just show them.
Right. So if you want to look at where your lines are drawn, eyebrows, let's go third by third. If we take a look at the upper forehead, we have to understand when you're holding a syringe in your hand, there's only 3 things that you can affect. You can affect the contour, which we call volume, right? You can affect the lines of that area. That's when we use toxin, or now we're going to show you how to use fillers to do that. Or you can affect the feature of that area, which in this case is eyebrow. Feature of the middle face is? Feature of the lower face is? Right. That's all you can do. So if you think in terms of that, you're going to say, okay, what about upper forehead contour? And this is where we're going to talk about it. For you, and you can show this to patients if you want, is an ideal female forehead contour is 12 to 14 degrees off of vertical. Okay, that's again from Hoffman's article where he studied beauty across all different races and ethnicities. The caliper here has a 12 to 14 degree curve to it. You can turn the patient's head sideways. Let's get perfect. That's great.
Actually good on the big screen.
Yeah.
So you're good.
And then you just lay this down on her forehead And look how beautiful she is. Look, do you see a gap? There is no gap. But as we age, the upper forehead becomes more convex, lower forehead becomes flatter, and the temple's hollow. So you're going to see hollowing or flattening in this area in patients when they get into their 40s and 50s.
We'll show you some videos of how we do that the next hour.
Right. And what happens is the fact that they become more masculine looking because they get a heavier brow, a promontory over here, which we prefer on a male rather than a female. So these type of injections, of doing brow injections, are phenomenal. I mean, it's something that was like, it's the masseter of old. Remember when we didn't see masseters? Then all of a sudden every patient seems to have masseters and we're treating. Now every patient seems to have a contour defect in their forehead. So there's the contour over there. There's the height, which we talked about. And there's the eyebrow position. So the eyebrow position, for you to understand, according to Phi, you don't have to show this to every patient, is the following. Where the eyebrows start should be at the inner canthus, like this. Okay? She's doing beautifully. And I get into a conversation about plucking eyebrows with my patients. My wife says, "You're out of your mind. What are you discussing eyebrows for?" Because
eyebrow shaping.
Bingo. It's more shaping. When Kent and I talked about it, we didn't talk about eyebrow lifting. We talked about eyebrow shaping. There's a difference. If you have an ugly eyebrow that's in the wrong direction like this and you just lift it, you're not doing anything. You want to shape that brow. So the eyebrow starts at the medial canthus. And its height from where it starts from the inner canthus should be sitting over the promontory of the bone. But if we do a reverse Phi, which is this way, let me see, can you crunch for me? Do you have any toxin in there? You do, yeah, I know.
Yeah.
Okay. So if we do a little reverse over here.
Of course, she's 25.
Of course. There we go. Where the eyebrow should start on her should be the reverse of Phi, 0.618 above the medial canthus. What do you think about, let's see if we can center her face. Which eyebrow do you like? She has one that's a little bit higher than the other.
It's a sister.
Yeah. This one?
Yeah.
Right. Because
Correct.
her eyebrow height over here is where it's supposed to be, and this one is a little low. I think her eyebrow position here should be there.
Perfect. Bingo.
1 or 2 millimeters above. That's what the Phi is showing me. When I measure this on patients who weren't, now that could be effect.
Subtle, but
That could be effect of the course. We know that happens too often sometimes, and we can talk about how you can adjust your dosing. If you pick up this as a patient who's coming in naive and you want to inject them, would I inject her higher or a little bit lower? Lower. By about 2 millimeters. Will I inject her superficial or deep? Deep, because the corrugator's deep. Even though the muscles over here are all blended together, we can't identify them very well when we do anatomical dissections. They are stratified in the way that they come in, and the frontalis is more superficial, and the corrugator is starting from a deep position on the bone and working its way superficial. The head of the corrugator here is deep, underneath orbicularis and underneath.
Transverse oblique heads there too.
So I would inject in the regular 5-point pattern. If I was going after her, I would take that point right over here, drop it down by about 2 millimeters, that's all, and make sure that I'm just above bone when I inject it. Don't catch any frontalis, and she'd end up with a brow that ends up elevating a bit like that. I think that would be awesome on her, okay? So the eyebrow starts at 0.618 of the intercanthal distance. It comes across 10 to 20 degrees in a female. It's more like 0 to 5 in a male. And then it has this tail extension over here, which I'm going to turn her towards the eyebrow that I like better, even though it's getting a little bit, okay, a little hard to see. There it is, but we can see it, okay? And in a female, the tail of the brow should always be at the level of the medial brow or higher, but never lower. We don't like to see this in females. She looks sad, okay? This is what we want. And ideally, we want it up just a tad like that, just a little bit higher. So if you were to draw a line straight across, you'd want the tail of the brow slightly higher than the medial brow. And that's the story over there. Kent will tell you now.
Measure the length of her nose compared to.
Okay, so we'll talk about it when we get to treating, I guess. We'll talk about it because this guy is the king of how he shapes brows. He uses a combination of filler and toxin. We talked about that again. I look back on our talks. It was back, I think, again around 2001 and talked about underpinning the brow with filler in order to be able to get that's getting on already. It's sort of old concept. Now, if we take a look at her nose, we're going to go, that's the things that I measure. When I'm with patients, I don't have to get into the whole detail over here, but this is how I think in terms of how I can optimize. Because it's not a situation, beauty isn't a situation of just banging out lines. Kent has these pictures that shows you all different types of eyebrows. Some thin, some absent, some straight, the unibrow, the coming down. What we are doing when we use toxin or filler is we're creating beauty, or youthfulness, or attractiveness, whatever. We're not there to bust lines out. We're there to create beauty. And if she had no lines, but her brows were like this, I don't think you've created beauty. So you have to take advantage of the fact that you can actually moderate or modulate where these brows are. So if we take a look at now the middle part of the face, where people have a little trouble with the caliper, we measure the intercanthal distance again. Okay. Where the nose should start on the female is at the lash line. So when she's looking straight ahead, if we draw a horizontal line across her eyelashes, okay, at about there, I'm trying to do it, that's where the female nose starts. For those of us who are rhinoplasty surgeons, that's how we try to have the frontal nasal angle take off over here. In a male, it's more at the level of the tarsal fold, a little bit higher. If you want to masculinize a female, have her nose start up higher. If you want to feminize a male, drop the angle of the nose down. It's not what I would suggest you do, but this is what happens. So if you measure the distance...
And you can, we'll talk about that. So you can actually change the length of the nose, make it shorter or longer. Depends on where you put the filler in the radix. So that little subtle thing can make the nose look more feminine, and it'll make it look longer or shorter.
Turn your head towards me, love. That's a girl. So we take the distance over here. If we go from the lash line to the bottom of the nose, now you understand why she is phi. She is 1.618 in length. If you want to get really cute about it, you can take the intercanthal distance, this intercanthal line, and then if you go from the intercanthal line, and I'll show you here, I just closed down my calipers. If you go from the intercanthal line, that will tell you where the tip of the nose should be.
Yeah.
So if you're planning a tip injection to go ahead and to get the light reflex on the tip, it will be the distance between the canthi from the intercanthal line right down over here. If you're looking at height of nose, we go ahead and we measure the reverse again. We take the bigger end of the calipers, we put them over here, and then when we look at the smaller end of the calipers, this should be height of nose. And she's pretty damn on. In fact, if I was going to do anything to that beautiful, beautiful little nose over there, I would give her just a teeny bit more height.
And I'll measure that in a minute here.
Okay. I would give her just a little bit of what we call a super tip break, okay? She's straight lined over here. I think if we were to just give her a teeny tiny little thing. Let me ask you a question. Is she an easy patient or a hard patient? Yeah, she's really hard. She's a 9.8 out of 10. Sorry to take off the 0.2. She's 9.8 out of 10. That means you have 0.2 to make her better and 9.8 to make her worse. And you cannot downgrade patients. You cannot downgrade patients. You cannot put filler in and then all of a sudden they come back and say, I don't think I'm as pretty as I was before. That's when I use my calipers, because that's when I'm struggling to see exactly where do I have to do the stuff. So nose length, 1.618. Intercanthal to tip is 1. Nose height, okay? Nose height is the 0.618 of this, if you're just trying to get an idea for this particular face. And nasal width at the bottom, straight line. Here, here, here. Volume of the lower 2/3 of the lip. Look where most of her volume is. Okay, it's mid. That's what Kent pointed out.
It's so easy to make those lower lips too wide, too big, and sort of like a number 2 sausage in a number 1 casing. So that's why you actually measure it, and we actually measure that intercanthal distance. And I actually mark it out because it just disciplines you to keep within that framework.
Right. If you don't have a caliper, just draw a straight line from the medial canthi and come right straight down, and that will define width of chin, width of this. Remember, lower lip, most of the bulk in the middle 2/3. If you go ahead and do this, come on, she looks angry. But the upper lip should show vermilion from corner to corner. If I was to treat her lips what would I do? I would try to balance her out from 1 to 1.618 because she's Caucasian. If she really had big masseters, I might be able to go ahead and give her a little more of the 1 to 1 that you see in Asians or in African Americans, but 1 to 1.618 in height. But I think what would really knock the ball out of the park with her is this. Look.
Yeah.
Giving her more width on the bottom. Because her vermilion's ending here and her lip is ending there. She needs that full width of the 1.618. So the upper lip is red from corner to corner. The lower lip tapers with most of the volume in the middle. We're destroying you here. We're tearing you down. You might actually drop to a 9.79. No, you won't. You're great. You're so
before
pretty.
you leave up here, could you comment about our temporalis here? Because she's not a teeth grinder, but she's a clencher.
Right.
Right? She's a clencher. And your eye knows that because watching her temporalis clench your teeth.
Well, look at it. See that? Look at
so,
the size
and if she's got her masseter here, relax it, clench again. I wouldn't treat her masseter, but she definitely is a clencher. That's why you get clenchers develop. This temporalis muscle gets a little bigger, and that's why. Anyway, you can measure that a little bit there.
And she is a little fuller on my side than she is on the other side. Clench again. Watch my finger move. Relax. Do that again. Yeah, you see she pushes. You
and
can
we'll
feel
talk
it.
about that a little bit in my Vouget D concept too, a little bit about that.
That's the OG curve, guys. Stunning. I'd love to inject her, by the way, because I think that if I injected her, and I don't see her on a billboard when I come back over here next time, I haven't done what I'm supposed to do. And the people will challenge you like that. I had that in Cape Town. If anybody here is a buddy of mine from South Africa, I went to Cape Town, and they really pulled one over on me because they said, we're giving you 4 people to inject, starting at 6 o'clock at night. I think we finished at midnight after my talking and everything. All 4 girls were runway models. Stunning. But a runway model is different, as Kenta will tell us, from a fashion model. And it's different from a billboard model. You cannot see sharp angles on a billboard. We don't like to see sharp angles on any feminine face, but the edgy look can work in high fashion and on the runway, but it can't work on a billboard. It has to be, everything has to be soft edges. And so they said, we want to see how many of these girls you'll be able to get onto a billboard by going ahead. And I had to measure every single one. It was a real challenge. 3 out of 4, by the way. But they were beautiful to begin with. Okay? So, and the 4th didn't sleep with the billboard guide. The other 3 did, so they got... No, I'm just kidding. Had nothing to do with me. Just kidding. Okay, so we have the upper third, middle third. Where people get caught up on the middle third is how do we measure facial width? So on this particular caliper, the way that it's designed to have this little extension on the bottom. Okay? The little extension on the bottom over here, you rest this to the inside, you can angle it like this, and the little extension will come down, and then you can take a look. Let's get this measurement just right. I'm going to try to do this over here. And what it does is it shows, if you get this to be like a plumb line, okay, that it drops straight down, I'll twist it a little bit like this, that there's a gap over here. There. I mean, now it's really exaggerated, but there it is. There's a gap of about 3 millimeters or so. It's hard to find sometimes. It's hard to see sometimes. It's a confidence tool. It's telling the patient, I see that you're a little bit off over there. And more importantly, it's for those patients that when they come in and they're completely bloated and they want more, you make sure that that thing rests on their cheek and you say, look, you can't go anymore. It's telling them, I can't. It's against Da Vinci's principles. I cannot inject. Do not enable patients to do things that are weird. Not all of them are wired for aesthetics. So we'll do this. We're going to go around the room and everybody's going to get a chance to measure the person next to you, whatever. We're going to do some simulated stuff as if a patient comes into your office. You have it in your eye. And we're going to take a look and see where the apex of the cheek is. So would I do anything? I mean, you look at her and you say, look at that beautiful cheek. Look at that. Can I improve on that? Do we have a marking pencil here? We do.
Yes, right there. Right there.
What I do in a case like this is it's very difficult for me to see how can I improve on that cheek. But I can. Okay. So here we go. What I do in the case like this is I have to see the cheek isolated for her face to see what I can do. So this is what I do with the cheek, okay? What I do is I draw a line from the outer canthus to the corner of the mouth for the midface.
And I do this on every patient. And my nurses do this on every patient. We draw this pattern.
This is Hinderer's line. Nobody knew who Hinderer was until I started talking about him, and now all of a sudden, this guy is like Napoleon. Everybody can mention his name like that. But who was he? He was a plastic surgeon in the 70s who was trying to figure out where do we put cheek implants in and where should they be. And he said, if you draw a line like this, the malar mound, the cheek mound, shouldn't be any more closer to the nose, any more medial than that. And basically what he was saying is if you have most of the projection here, they start to look like Cirque du Soleil, which we don't mind up in Montreal, but you guys don't want that all the time over here. So this is a line that tells you that's where the inner part of the cheek mound should end in a female. I'll show you in a male afterwards. Then you draw a line that goes from the mid-tragus right down to the commissure again, like that. Okay, I'm a little bit off there. There we go. Okay? That defines the lower border of the malar mound. How did I get that line? Just by looking at every beautiful woman that possibly come into my office, going to a modeling agency, measuring models over there, looking at all the pictures, 3/4 of all the women in the magazines and saying, where does their mound end? And then we know the cheek shouldn't be any higher than the lateral canthus in the temple. So we've defined a triangle that we can now just draw in a nice little oval. This is her ideal cheek mound. If you want to make her look like she has cheeks like Natalie Portman, who has some of the best cheeks in the business, this is exactly how Natalie Portman's cheeks measure out. And if we look at it, what we're looking for is smooth contour throughout, and she's got that. She has a nice smooth contour. So are we finished? A lot of injectors, if they got this result, would walk away and say, I'm done. And they'll get a nice result. But good is the enemy of great. And we have to generate great results. It's the only thing that insulates you against the competition across the street. Not dropping your prices. It's by creating better results, by having patients literally clamoring to try to get into your office. So we have to see where is her cheek apex, because that's the last part of the cheek mound that we have to understand is going to reflect light. And as Kent is going to show us, it's all about reflection of light and shadows on the face. We are magicians. We can make the cheek appear like it's popping out just if we get the light to reflect in the right place. And if I look at her now and I turn her cheek just a bit over here, I'm going to mark it out, I would tell you that probably that's the most projecting part of her cheek. Do you agree? Somewhere about over here. Where do I think it should be? We're going to grab her outer canthus over here and the orbital rim. So you have a thickness. Feel it on yourself. You have a thickness to the bone over there. Okay? You take the midpoint of it. Okay? You take the midpoint of it as if you're taking the exact bisection and you drop down a plumb line like this.
You can't feel the midpoint. It's about 1 centimeter from the medial part of the orbital rim.
Correct. So now she has a vertical line drop down over there. You see that? Perfect. Look, that cheek mound is sitting just about where you think it should be. And then what you do, if you don't have calipers, this is the way I do it, is I look at where the alar groove is and the top of the tragus, and I draw a line coming across that goes between both. Like that. Her cheek, and if I was to measure her with my calipers, I'm telling you right now that that is going to be her 5 point. Okay? I can see it right now that that is exactly where her cheek should be. Look, it's 1.618 from the medial canthus.
It's not a spot, it's a zone.
Mm-hmm.
It's not a pinpoint, it's a little bit of a zone.
You got to be close to it. She's off here by 5 millimeters, 8 millimeters. Will it make a difference? I wish I could stick a needle in there now to show you that if she was looking like this, let's get her straight. Let's look in the camera. I'm trying to get you lined up to the camera. You just look straight at the camera down there. Atta girl, okay? How am I going to do this backwards? It goes this way, and then it goes, nope, this way. There you go. Okay, like that. So, if we were to take a look at this, and I was just to do that, I want to ask you a question. Look at her face now. I'm going to add volume, okay? Watch. I'm adding volume. Is her face narrower or wider than the other side? Narrower. You need volume to narrow a face. Exactly opposite of what you think. If we were to nail this thing right over here, you are going to see, look, it's ridiculous. It's absolutely ridiculous how you can change with 0.2 cc's of product. Okay? Because the light will catch off this area over here and give her what people are craving for, which is the V-line in Asia. So when I go to Asia and they give me these big round faces, these huge round faces that I have to work with, whether they're Chinese or whatever the story is, there you go. When they give me these round faces, they say, what are you going to do? I say, I'm going to add volume. I say, are you out of your mind? I said, no, because I'm just going to put in a teeny little bit of volume at the right point over here, and when the light catches it, you sit the patient up and they look like this. So you need volume to narrow the face.
Now,
go ahead.
Maybe, if you look close here, now that we've drawn this, patients usually can't tell the difference between two sides, because remember, each side of the face are not sisters, not twins, they're sisters.
Right.
So which side of her face is fuller?
We got to get your head straight. There we go.
No. Her right side. Her right side is full. 80% of the population, the right side, whether you're this side's a little bit fuller. And that's quite it's subtle, but it's definitely a little bit fuller. And that's just the genetics of faces. It doesn't seem to matter whether you're right-handed or left-handed. The right side is always a little bit fuller. Sometimes it's very striking. And the other thing is to measure. We talked about her nose, and her nasolabial angle is, as Dr. Swift was saying, should be, that nasolabial angle to be ideal, probably should be up a little tiny bit. We actually measure this. This is an obtuse angle protractor. And normally in her genetics, her DNA, it should be 95 to 110 degrees. So if you look at her side view here, so what is her nasolabial angle? What is this angle?
When you're looking at nasolabial angle, by the way, let's do this. A lot of people get confused because they start to measure the angle between the columella and the lip. That's really not the nasolabial angle. If you want to find out exactly the cant of the nose, it's actually a line drawn through the nostril sill. Okay, so it's where the nostril base is and where the nostril, I'm trying to do this backwards, and where the nostril ends over here.
Right.
If you draw a line through that, that really gives you nasolabial angle, correct?
Yeah, sometimes it's hard to measure that, but that's because sometimes the columella hangs down a little bit, sometimes it's a little bit higher.
That will fool you. That will fool you.
And her nasal spines here, you can feel on these little spines, are quite recessed. So in patients that have that recessed nasal spine, you can't lift them. But I would say hers is probably 100 degrees. So we would just measure this a little bit, see if you can see this here a little bit. Yeah, and it's right on 100 degrees. Obtuse angle is what you're trying to obtain here, more than 90 degrees. So in Asian patients, skin of color patients, it's more like 80 degrees, and in men, it's more like 85 degrees. So that becomes a crucial part of your measurements there.
So mid-face measurements, nose, length, height, width. You could even do nasal width if you want higher up, because it should be the reverse. I don't want to start getting down to it, but if you do this, we said that should be the width here.
Yes.
Right? And then the width over here should be somewhere around that. Okay? So it's, again, the reverse. If you really want to dissect it down, you don't have to be that intricate. So for contour, eyebrow position and shape, temple in females should be flat or slightly concave, maybe a slight convexity to it, as my friend Waffle says, because he deals mostly with an Asian population, and they have a little bit. But if overly convex, that's a masculine feature, I would reduce the temples. Okay?
And you reduce it just the same way you do masseters.
Right.
Same way with neuromodulators.
Correct. And in fact, that beautiful pictures, actually in our chapter that we just wrote on that you have to treat the temple. I don't know if we'll get an opportunity to do it because you don't see the results, but you have to treat the temple the same way that you treat the masseter, meaning that your injections have to be deep. There are two layers. There's a superficial and deep layer to the temporalis muscle, and if you only catch the superficial layer, it softens and the deeper layer herniates through it, and you get this funny looking bulge over there.
Same as the masseters.
Exactly. So you got to make sure that you ask them to crunch. We probably won't get an opportunity. You can really see it here on her. It's beautiful. It's too bad that she's a little weighted out. Maybe you can see it better.
Yeah, you
on
can
the
see it pretty good.
Yeah.
You can see it pretty good.
Give me a crunch again. You can see this. You pick the high spot of those two, and about a centimeter apart, you'll put in, and I would put in probably on her
Sided?
the equivalent of maybe something around probably 15 units of Zeo or Botox, or maybe 40 units of Dysport. Okay?
And she's a right-sided chewer, clencher as well, because the masseter's a little bit bigger on that side, and the temporalis a little bit bigger on her right side.
And then we get down to the lower face. We talked about this, and now we get down to the lower face, which for me is the most difficult area to nail, to get a good result. Why? Lower face, think about it. Mid-face, lower face, two buddies who go out drinking at a pub. I always like to make it a story, so you'll remember it. And they get hammered. They can't walk. They have to get home. But they're barely able to walk. What happens? They stumble out of there, but guess what? The lower face not only has to stumble home, but he has to carry his friend with him. Because the lower face provides some support to the mid-face. Upper face does nothing. It just sits there and watches. So it's got its own issues of volume depletion, and it has structural loss that is affecting the middle face as well. So this is the most difficult area for me to inject because it's volume, structure, and proportion in a dynamic setting. A moving mouth, how the mouth relates to the nose, the chin, the width of the face. And as Kent has taught us, it's not a chin, it's a chin zone. 3 dimensions. There's height, there's width, and there's projection. So you have to work in the 3D box over here. They see themselves in 2D, but you've got to work in the 3D. So it's a very difficult thing to do. What are the caliper measurements over here? We talked about width of mouth. You can show this to patients by taking the distance over here and showing them the width of the mouth and explaining to them that what you'd like to do is do that. A little bit of increase on the width. I keep on lifting up the wrong one. Everything's backwards on the camera. You've got to get used to it. Look at that. And if you wanted to do anything in the lower lip, it would be centrally. Give her just a little more like that, but do not give her the dour look by giving her full lips like that. I think that's dour. If you want to take a look at height proportions on the bottom of the face, what I do is I show patients that if you go ahead and you measure the distance over here, and then you go ahead and you take it from the what we call the fissure, which is the contact point between the lips, that should be the height of the lower face. And what I would do on her probably, let's take a look. Well, she's pretty damn straight on. Of course she is. That's it.
She's pathetic.
Yeah. Very fi. You know, I come home and I'll tell my friends, see anybody that was pretty over there? I saw somebody who was so fi. They were just beautiful. Beautiful smile too. Do you know that it's been shown through studies that we are more attractive when we smile because we drive our face into 5 proportions more when you're smiling than when you're not smiling? Interesting, huh? So there's the height that we want to talk about over here. There's the width that we want to talk about. And as far as chin projection, look how good she is here too. The easiest thing that I do is I just take the very front portion of the upper and lower lip. The upper lip should be less full. Can I say that? Yeah, should be not as full as the lower lip, but should project by 2 to 3 millimeters more. And if you run this through, this is a modified Ricketts or Steiner line, then her chin in a female should be touching that line or 1 millimeter or so behind. In a male, it's got to be touching that line or a millimeter or 2 in front. Okay? So we have projection, we have width. Got it? And then we come to lower facial width. And boy, I wish I had my friend Stephen Liu here from Australia, because he is absolutely the master of slimming and giving exactly the right proportion to the lower face. If you want to take a look at ideal proportions, and it's difficult to do this again, but we're going to try. There's a way to measure that with this calipers, but I'll just try to show you very simply. What you do in a situation like this is you want to get this distance here, which is the distance between the eyes. Okay? Remember, this is 1.618. Ideally, she should be 1 over here. Okay? So when we look at her straight on, let's see if I can do this for you. Maybe I'll do it this way, and then we can sort of get the caliper to sit fine like this. But this is pretty much where you want to be, 1.618 to 1 over here. And so patients who come in who are wider like this, you can see her lips look out of balance now. She's very close to it. If she had very strong masseters, can you clench down, which she does, okay? She can stand the extra facial width. She needs that 1.618 to balance out her face, okay? That's why Angelina gets away with her lips, guys.
Yeah.
She gets away with those lips because she has very strong masseters. She has 1.618 to 1 width over here, so she can get away with that fullness. But if you took her lips and put it on a narrower face like this, it doesn't look right. So you can't put big lips on a small, narrow face. If you have a patient with big masseters, go for it. If you have a patient who doesn't have big masseters, then wants to have their lips done, then you have to explain to them, yeah, I can give you fuller lips, but I'm going to have to balance it with the lower part of the face and increase a little bit of your volume down over here. And they'll go for it. It looks better. So they walk hand in hand with that, okay? If you're going to reduce the masseters on somebody and they have big lips, they're going to look funny.
Arthur, show them the lip, the filtral column measurements.
Yeah. So what we do sometimes is that you can measure. There's kind of interesting things that you can do. You can measure, again, this is just esoteric, but if you're really getting stuck with a patient and you're saying to yourself, I'm just not getting the result on the lips that I want, you measure the distance between the bottom of the nose, okay, and the upper lip, and that's going to end up being, the phi of it is going to be where her Cupid's peaks are and where her filtral columns are. And that will also dictate what the volume of the lower lip should be for intrinsically for this area over here. So again, this distance is 1, makes this distance 0.618, makes the lower lip thickness 0.618, and if you measure the lower lip thickness, then you get the 0.618 of the upper lip. So if I really wanted to nail her exactly, and you really want to do this on patients who are models and patients who are constantly on TV.
And then measure the length of her lip from the filtral column.
Correct. So then what you can do, if this is the width of her mouth, which we said is the intercanthal distance, if this is the width of her mouth, then from opposite filtral column to here, this is 1, this is 1, this is 1.618. There's all little phi proportions within ideal lips as well. Remember that in people of color, in Asians, African Americans, and people of strong Mediterranean descent that have color and width over here, that you can get away, I'm going to poke you in the eye eventually, that's what I want to do. You can get away with a 1-to-1 ratio. This works well, okay, in some races and ethnicities. And that was pointed out to me by Julius Few, who's a plastic surgeon friend of mine from Chicago. He said, we can handle 1-to-1. I said, yeah, you can. So that's kind of like the measurements. So let's very quickly.
Do that later.
Yeah, let's do that.
Very quickly.
Okay. Yeah, as soon as we get done with this,
we're going to do it on each other, but very quickly, let's go over face maps with her, because this is a case where you may have to do that for a checklist. Facial areas, upper third, middle third, lower third, and periorbital. What would you score her forehead if you had to score her forehead out of 10? I'd give it a 9, maybe even a 9.5. There's not a whole lot to do there, and she's already had a little bit of work done. Her cheeks, I would say her cheeks are also a 9. Her lower face, pretty much a 9. Okay? Periorbital region, well, if we could take a look over here, maybe an 8.5, 9. I got it. You guys can't see it. It's a little bit washed out. Okay. So we look at that, and then we say, okay, we've got an aesthetic assessment for each. What about contour? The contour of her forehead is convex. That's what we want. Of her temple is a little convex. We're going for flat or concave, so maybe this is an area that I would treat because I'm looking at contour over here. We look at contour of her cheek. It's a beautiful contour, but I want to maximize the apex on her. And we're looking at contour of her chin and her jawline, and it's absolutely stunning and beautiful. And it's the right contours. It's not wiggly-waggly. It's not irregular. That's good for contour. Skin envelope. How would you describe her skin? Thin, thick, or average? I think average to thick, right? Something around there. She's not thin. What does that mean? Any products that you choose, you have the whole portfolio to work with now. Okay? If she was very thin-skinned, you'd have to go with the thinner products. And if she's thick-skinned, you have to go with the thicker products. Simple as that. So that's the envelope. M, movement. Raise your eyebrows for me. What does she create? Lines, folds, wrinkles. She creates very few little lines. She's had treatment over there. Give me a frown. Okay? Can't do much over there. She's doing great over there. Big smile. Couple of little crinkles. That's a Duchenne smile. You want to create wrinkles when you... Don't wipe them all out, guys. You got to remember that the orbicularis muscle is also an elevator of the cheek. If you take away that, the smile ends up being central smile, and they smile like that. It looks weird. A Duchenne smile is a sincere smile.
Spontaneous smile.
Spontaneous smile that creates a couple of wrinkles. If you ever try to smile at somebody without making any crow's feet, they look at you and they say, well, he's not sincere. He's just sort of, you know. So you need a couple of those over there. So those are the lines over there. We want to take a look. Give me a big smile. Show me. Great. Beautiful. 1, 2, 3, 4, 4.5 teeth. She's got just beautiful stuff. Maybe pulling a little more on the left side than the right, because look at the fold that she's creating on the left. She's got a little more pull of rhizorius and zygomaticus minor. So if I really wanted to really have some fun with her, I would myomodulate that side by putting in a little bit of filler that will prevent her from pulling and give her a more symmetrical smile. That's an interesting thing to see. So I'm looking for hyperdynamism. Okay. So that's in the movement aspect. That's the M of face maps. Amount. Okay. Is she 3 syringes? Is she 1 syringe? Maybe. Maybe between 1 and 2. What do you think? A little thing here, a little thing there, and that's it? Great. So she comes in and says, you know, I only have enough money for 1 syringe. Really? How much do I charge for a syringe? I don't know. Don't you charge $600 or $700 for a syringe? I said, no, I charge for the result. She says, well, I have $700. I'm going to tell her, you know what? I can do some magnificent things on your face, and I think that I can create outstanding beauty for $900. Can you go for that? I might not even need the 2nd syringe. Maybe on the next patient I will. I don't care. I'm giving her the result. It's like when you treat the nose. You're going to treat the nose. You're not going to use a full cc of product. If you charge just for the product, it's ridiculous. You're not going to charge $50 to do a nose. It's a high-risk area, and it has a great reward to it, right?
Yep.
You're charging for what? The hand, and making sure that when you have the hand, it's the right ball in the hand, right?
Yeah.
This is what Kent is now telling us, which I think is a great idea. So now we know amount, that's M. Platform. We're going to go through that in the anatomy section, is to understand that the product I'm going to choose, if I'm injecting to increase her apex over here, am I going to be on bone or on soft tissue? I have to understand where the bone is and how deep it is. I can use a product that's a little more robust because she has average to thick skin, and I'm putting the product deep, then I'm going to be able to give her that little bit. Oh, look at that. Wouldn't you just love to do that on her? You know, it's great. And again, the same situation if you're working on a chin. If you're working in a tear trough, which I may have to do on her, am I going on bone? Yes, but if it's bone and it's very superficial, I can't use a very thick product. I have to use a thinner product. So you look at the platform, and then you devise your strategy. Finished. You've gone through face maps, and you know exactly what the story is. She, to me, is a 1 to 2 syringe patient. She's going to be a caliper patient for me because she is so beautiful. I have to make sure that I do not downgrade her. I'm going to spend a little time with her because we don't spend enough time analyzing the aesthetic face. And I'm going to say, okay, in my mind, I got to use maybe 1 to 2 syringes. She's paying for 2, whether I use them or not. It's another story. But she's going to pay $900. She will go for it. I promise you she will. And then just by giving her the confidence, because we talked around the calipers and everything, her friend will get it done too. Because I'm going to upgrade her, her friend is going to look worse in comparison. People are asking about that apex, the sort of the high point, whatever the story is. You can find it 2 ways. You can drop that vertical line and take a line that goes from the groove of the nose to the top of the tragus, where those 2 lines intersect will give you this point. Or if you're using calipers, just draw the line that goes from the groove to the top of the tragus. And when you measure, wherever, going from the inner canthus, wherever this sweep falls across that line is where the apex is going to be. Do you understand? So that will tell you how much of an angle you have to do. That brings me to the male cheek, which is different than the female cheek. If she was a male, what would the difference be? A male cheek, first of all, the difference in the forehead in a male is we're more sloped. We have a much steeper angle over here and a flatter forehead. And we have more of a promontory over here. So you can soften a promontory on a female. You can do that on a male as well, but not as much. Leave them a little bit of a promontory. Males have to look like they're going to club you over the head and drag you back to the cave. All right? Okay. So that's for the forehead. Male temple, flat or slightly convex. Okay? Expressing big muscles. A lot of these guys are really getting their body fat down to nothing and they're a little bit hollowed over here. Give them a little bit of volume. It's going to make them look more masculine. Male cheek, broader, wider, not as strong an OG curve, more subtle OG curve. If you wanted to see the lines of a male cheek, instead of drawing hinderers from the canthus down to the mouth, you draw it from the outer iris. Okay? So it's more of a vertical line like this in a male. Got it? The line that comes here that goes to the mid-tragus is a line that comes from the mouth that goes to the bottom of the tragal notch. We're opening up that cheek. The height of the cheek is still the same. When you draw the circle on a male, it's going to be more vertical than it will be angled. Females should have that angled look. Males should have a little more of a rounded look, okay? It's going to be a little more rounded. Have you got that? Am I making it a little clear? You want me to draw it on her? I figured. Okay.
Also think of it like a baseball catcher calling for the ball down and in.
That's right.
So the male cheek is down and a little bit medial compared to the female.
So watch.
That's how you think of it.
So this would be a male cheek would come to here, whereas a female cheek would come to here. A male cheek comes across like this instead of across like that. So you see how we're opening up these angles. These angles, instead of being like this, they're now this. Instead of being like this, they're now vertical. Still don't want to see a cheek in the temple. And now when you draw a male cheek, look how it's more rounded. And the angle is more like this than it is like that.
And more subtle.
Okay?
Subtle.
As far as the apex now, like Kent was talking about, instead of going from here to here, go from the base of the nose to the bottom of the tragus. So here it's from here to here. We dropped it down. Okay? If you take it now from the inside over here, instead of, it's basically going to be, this is a female cheek. I'll go over this again in a second. This is a male apex over here. So like Ken says, it's how you get a batter out in baseball. You throw the ball down and in with a hard fastball down and in to cram him. The cheek apex is lower. And when you measure it on a male, it's going to come out to be, instead of on the arc over here, it's going to come out lower here. So if I wanted to masculinize her, I would do something like, look, like that. Okay? So again, that point again, so you understand, if you're using calipers, is go from the bottom of the nose across to the bottom of the tragus. In a female, it's from the upper part of that groove, which is the alar groove, to the top of the tragus. And then wherever your caliper at 1.618 from the inside of the canthus falls on that line is where ideally the cheek apex should be, and make it more subtle in a male. That light reflex over here will give him an impression of having a little more facial width lower down. Okay?
Now, these we have in every one of my rooms. There's a little tray full of these. I'm a non-coffee drinker, but these are, coffee stir sticks?
Right.
But these are medical grade. You get these at Costco. So these you use to draw your lines because they're narrow and they're very nice. Like you can draw that from the inner canthus down to the alar width here to, for instance, get the maximum volume of the lower lip and draw all your lines. So it's easier to see and use. And we actually wet these and bend them just a little bit to make a form so it forms the cheek. So that's a neat little gadget to have that's easy to draw.
Which brings up a point. How many of you actually draw on your patients?
Aha!
I love
Fantastic.
this group. I love this group.
Fantastic.
That is amazing. You know, the first time, I think 3 years ago when I did the first session with you guys for Aesthetic Blueprint, I don't think there was a single person that picked up their hand on that. How many of you here are plastic surgeons? 1, 2. Where's my other buddy? There he is. Okay. Do you ever go into a breast augmentation or a tummy tuck without drawing on a patient? Never. So why would you not do this? The pencil is your confidence tool. You know what I do? You're going to think I'm completely nuts. I already know I'm completely nuts. If I have a patient who's skittish and really worried about everything because they've had a friend who had something done and they didn't like the way it looked or whatever the story is, I say, listen, I'm going to measure you. You're measuring me? Yeah, I'm going to measure you. We're going to do everything. Even if it's in my head of what I want to do, I still take out the measuring. And I start to draw lines. And if I have nothing to draw and they're sitting back like this in my thing, I say, okay, I'm just going to plan out what I'm doing. Then sometimes I'll just do something that looks like this. And I'll sit back and look and I'll say, okay, we'll put one over here. And I think we'll put... The point being that this is the most important tool that you can use when you're planning any type of procedure, because it gives you the confidence that you have a plan, not with this little fun thing that we did, but you have a plan. I was drawing an XO on you, by the way. It was your move. And it gives the patient the confidence that you have, that you're just not firing at will. Okay? So I don't do it on every patient, but trust me, those patients that you know are the tough patients, the ones that are going to come back and try to get their pound of flesh afterwards because it's not exactly this right that way. If you show them that you're marking and you're going to do it exactly the way that it's supposed to be, and you show them what you're trying to create, they're on your side from the beginning. Questions? Fire.
One more time, Dr. Swift.
Fire.
Just show
Yeah.
your calipers
Right.
from the medial canthus
Right.
to where you are dangling the other end to see that apex.
You heard that I dangle, I
Apex.
guess, huh?
So what she wants to know is how you can do it vertically with the.
I think I lost my calipers. You have them. Somebody has them. They're over there.
You want a pencil?
No, it's okay.
You
Okay.
can do it with vertically, but you can also do it with the caliper. The calipers gives you
Okay.
a zone, so he'll show you
So,
again.
Your measurements are from the medial canthus to the ipsilateral cheek. Okay? I'm sorry. How's that? Oh, sorry. The camera's not on. Can we put the camera on, guys?
There we
Great.
go.
So your measurements are from the medial canthus. This is the main thing. This is your foundation. You know, when you meet somebody, what is the first thing that you look at? Why? Why are you drawn to their eyes? Well, a lot of the people that I'm drawn to are a little shorter than me. So I'd be looking at... No. Right. Windows to the soul. The reason that we engage in eyes, it's instinctual, is because the eyes will tell you the soul of the person. And what you're looking for is friend or foe. You can see that in the eyes right away. So the first thing that we look at is the eyes. And then we scan away from the eyes. These studies have shown this. We start to scan away from the eyes, right? So if you don't get proper proportion based off the eyes, that's why I think that once we start to scan there, we've already set that in our heads. We're looking to see, really, when you look at somebody who's beautiful, how proportioned they are to where you first look at them. And so I think the base of using the intercanthal distance is key. And then afterwards, trying to find as many of these 1.618s or 0.618s that you can find on
About
the
3
face.
minutes.
Yeah. So that's what we do. So everything I do for the cheek is pretty much based off the inside of the canthus. You have that little red carbuncle. Don't stick your thing inside there, but just go to the inside of it. And then you have a sweep. Okay, this is all 1.618 on the arc. So where that arc intersects down low, what I told you, where it intersects that line, that's the male cheek apex. Where it intersects the line higher up is a female cheek apex. So in transgenders, if you're trying to make a male face look more feminine, you nail them high and outside.
Up and out.
Up and out. Exactly right.
Let's do the apex last. You give the cheek what it wants and what it needs.
Correct. And that's how we look at it. When we do injections, I'll talk to you about the fact that that's how Kent and I look at it. We see what the cheek is telling us it wants, where it's missing some volume. We give it back. Then a lot of people would say, go home. That's not what you do. Then you give them what it needs, which is an apogee or an apex or a nadir or whatever you want to call it, the mountaintop, the peak, in the right place. That's the last little injection that will bounce the light off and will drive 5 more patients into your office. Guaranteed. Okay?